Good morning, everyone. Sorry to interrupt the what is the first or perhaps second cup of coffee, so forgive me. But I want to go ahead and get things kicked off here. So good morning again, and welcome to the first IRD Breakfast Symposium. It's just wonderful to see a lot of new faces and folks that I haven't met along the way. I'm Dr. Eric Daniels. I'm the Chief Development Officer at Kiora Pharmaceuticals. And on behalf of my colleagues at Kiora as well as at Vision Australia, I just want to thank each and every one of you for taking time and starting your day attending this event. And this event, from our perspective, has a simple primary purpose, which is really to bring members of the IRD community together to raise awareness, share knowledge, and continue to inspire not just hope, but progress. I will keep my comments limited so we can get to the content. I do want to take this opportunity for an acknowledgement of country. We acknowledge the Kaurna people are the traditional custodians of the Adelaide Plains and pay respects to elders past, present, and future. We recognize their cultural heritage, beliefs, and relationships with the land and acknowledge that they are of continuing importance to the Kaurna people living today. There are a lot of people to thank for putting on an event like this, much less the first event like this. And I'll do so at the end of the program so we can get to all the speakers and the questions. But for now, just know that you'll hear from really, I'm honored to have many of the leading voices in custodians, really, of inherited retinal disease community here in Australia. And while one breakfast or a few cups of coffee and some fruit does not come close to doing the subject justice, it hopefully, is a step and brings us a little bit closer. So we'll definitely have some time for some Q&A, both during the sessions, as well as for those who are able to stick around a little bit after the event. We do have a little bit of time in the space. A beautiful space it is, and a beautiful morning to be able to share with you. So now that hopefully you're fueled with a little bit of coffee and soon to be breakfast, I'd like to get started by introducing Chris Edwards. Chris is a member of the Vision Australia executive team. He has extensive experience in advocating in government policy, and we're going to hear his pathway and his activities. I also happen to know he's an extremely exceptional and wonderful, warm person. An avid skier, and has an absolute just wicked sense of humor. So I'm so pleased to see him, and I will take this opportunity to welcome Chris to the lectern.
Welcome, everybody. Thanks, Eric, for that lovely introduction. It's so great to be here to this first event that is focused on IRD in Australia. On behalf of the Vision Australia team, it's been an absolute pleasure working with Kiora in progressing this event, and I'm hoping it'll turn out as we all hope. And really look forward to the discussions that we're going to have around this very important issue, not only for myself, who's a retinitis person, but also for many of our clients at Vision Australia. To introduce myself, as Eric said, I'm the Director of Government Relations and Advocacy. I'm somebody who's blind and have no light perception whatsoever, and use a seeing eye dog called Eva. Adelaide's quite a fond place for me in recent times. A year ago I had a great deal of pleasure coming to Adelaide as a participant in a trial with Kiora. And I saw light for the first time in about 15 years. And it was certainly an amazing experience, and something that was very exciting, and I'm looking forward to hearing about other activities that are happening that could also create these amazing opportunities for people like myself. Most people would know Vision Australia as a service provider, providing everything from training in assistive technology, helping people out at home, to do daily living tasks, to learn how to do mobility, seeing eye dogs, etc. We actually provide services to over 39,000 people a year across all those services, including our library. So why is what people are less know about is that Vision Australia is a key advocate across Australia and society. And why is this important? That combination of being a service provider and an advocacy service. Let's take two scenarios. In this case, a person has RP. The disease has now progressed, so they can no longer feel comfortable and confident about walking around the community. So the person takes some initiative and they come to Vision Australia to seek some help. Firstly, they go through a whole lot of processes, but then complete an orientation and mobility program. That program teaches them, how to use a white cane, both indoors and outdoors. It teaches them some travel routes to the standard sort of things that they might be doing within their life at the moment. It might teach them around some orientation around their workplace so that they know how to move and learn about things that they probably didn't know that existed in their workplace. And it teaches them things like public transport and those sorts of things. And whilst this works for them in most part, they might decide, okay, I want to actually take the next step and get a seeing eye dog. And the seeing eye dog, it has the ability to be able to provide even greater confidence and access to some mobility. So they go through the assessment process, they're matched with a dog and complete a 4-week intensive program. So once they've completed that program, over the next sort of 6 to 12 months, they tend to continue to progress their confidence and their skills as a team to be able to tackle all sorts of different environments. To the point, like myself, I can have no problems these days in being able to leave home and go to any city, to any location, and do that completely independently. And so, as you could imagine, this freedom and these skills and the knowledge with the resources that we've given them at Vision Australia, that person feels on top of the world. And it's not just about Vision Australia. There's obviously other services in Australia and across the world that can do the similar things. And so it's a great thing that Vision Australia and these other organisations are able to solve what is their mobility challenge caused by inherited retinal disease and their loss of vision. So let's go back to the scenario. So that person that's got all these skills, got all this confidence, are at work one day. They've had a full day of work, they've gone to lots of meetings, they've nailed a presentation, they've written a report that's convincing around a business case. They're highly capable people that have really achieved and feeling great in life. Their wife rings up and says, do you want to come out, let's catch up for dinner that evening. And so because, probably like me, working too long and running late, Instead of catching the train that they normally do, they decide to catch an Uber to the restaurant. So the first Uber rolls up, and you go to hop in it, it refuses you. Okay, why is that? It's because the person was travelling with a seeing eye dog, and the Uber driver says they don't take pets. Even though the law is quite clear on the difference between a pet and an assistance animal, this driver's not. And so the driver cancels the job, refuses. A second Uber comes up. Believe it or not, the same thing happens. And the third Uber welcomes the person, adjusts the seat so the dog can get in, and they head to the street. That might sound like not a realistic thing in Australia, but believe it or not, that happened to me just last week. So at the end of the Uber trip, we get dropped off at the end of the street. Not because the driver was incompetent, it's because of the nature of where we were going. There's an easier drop-off point 100 metres down the road. And we're walking down this, footpath through this shopping strip. Instead of what they were actually faced with was they had numerous obstacles in their way. There was street furniture. There was those advertising A-frames. There was a number of e-scooters that were just parked in your way. And whilst walking down, an e-scooter whizzed past and almost hit the person. What these events do it is really, shaken that person's confidence to be able to travel independently. And so eventually they use the combination of some assistive technology on their phone that can help sort of determine where exactly they are, and their seeing eye dog to find the restaurant. And so walk into the restaurant, and the owner of the restaurant says, "Sorry, you can't come in here because you've got a seeing eye dog. We don't take pets in the restaurant." And, there ends up being, quite a significant debate on whether you're allowed to, and, there's the option of ringing the police, etc. But what the important part is, it's the combination of all these refusals around refusals around transport, refusals around premises, and these unclear pathways and near collisions that really do genuinely impact that person's confidence to be able to move around their community safely, confidently, and be able to do it in the way that they were taught when first trained. So, the issue is that without some advocacy, these things occur, and despite the training, we still face them. The second scenario is exactly the same. That go to meet for someone for a restaurant after work, but this time, with some work by Vision Australia and the sector, they're picked up by the first Uber. The footpaths are clear from obstructions, and e-scooters aren't riding on footpaths, and even electric vehicles can be heard, so that when I'm crossing the road to get to the restaurant, I'm not hit by an electric car that I can't hear. And this time, the restaurant owner welcomes them in and has already thought about a seat that is most effective, that works for me. So for these things to happen, there's three things that need to happen, and these are the focuses for Vision Australia. We have the right policies, and so the legislation, the local council policies, everything, all mean that that helps people get access where needed. Secondly, and just as importantly, those policies are enforced, and so we work with regulators and other people to ensure that there's one thing having a policy, but the other thing is to make sure they're enforced. And so in recent times, we've worked with Uber, for example, and developed to ensure that they've got mandatory training to ensure that every driver to remain on the system understands what an assistance dog is, and that they have to by law. And the last thing is education. And so whilst Uber agreed and worked through that policy, and we've worked through the regulator at Safety Transport Victoria, we need to continually educate that these are important things to provide access. So this is all the basis of our work. And our work, has some other priorities around it to ensure that people like myself and people with IRD can live independently. The key things that we're focusing on at the moment is NDIS and aged care reform. Both of these massive programs for Australia are going through significant reform. Whilst they're in NDIS, people who are blind and low vision make less than 4% of the cohort, it's important that we're not forgotten within some of the policy changes. And the same thing with aged care, that whilst it's focused on people that are frail, we want to ensure that people that are older but have a vision condition, which everyone knows is very common as you get older, that the system is best meeting their needs. We also are focused on employment. Only 24% of people who are blind or low vision in Australia are in full-time work, which is a statistic that's completely unacceptable. Education, to ensure that people at school can have appropriate access to the right supports, to the right technology, to Braille. Interesting enough, one of the issues just was brought to me last week, that in New South Wales, that if you're a student and you're on the youth program and get a seeing eye dog, you're only allowed to bring it to school if you have an adult to look after it for you. That's very practical, isn't it? And ensuring that technology works. One of the key enablers for someone like me and the ability for me to be able to present today is to have technology that talks to me in the headphone that I'm wearing. And so whilst technology is a super enabler for our community, it equally as much, there's been occasions when you go to try and book an event or book an airline ticket and the website's not accessible, it has the same sort of barriers as I was faced in the examples that I talked about earlier. And then lastly, the built environment to ensure that that's going to meet our needs. Some of the new advancements around the built environment, start blending with technology too. So has anyone who's here today that's blind or low vision gone to one of those new buildings which has a lift panel to press the button for the lift, and you're faced with a touch screen that's got no accessibility features on it? Impossible to use as someone who's blind and low vision simply to get up to level 2. And then finally, transport is always a key area. When you don't drive, we need transport that is going to work for us, that has the right audio announcements, that tells when something's coming and also when to get off. So, in summary, Vision Australia has more recently recognised its role in advocacy and the importance of not only that our job is to teach people those knowledge, the skills, provide them with the confidence to have the attitude to be able to move around and do things independently. But it's actually, it's society that is creating equally as big as barriers as the person not having the skills. And it's something that, with continued focus on that policy enforcement and education, we're confident that over time we'll be able to change the community to provide improved access. And finally, the Vision Australia, in its work around this education and information, is we've recognised in more recent times that the important work that you researchers in the room do, these trials that are happening around very innovative treatments like the one that I experienced, we've recognised that no longer that it's other people's role to be able to inform our community of that. Vision Australia is happy to and is keen to play a role in ensuring that people can make informed choices about what's happening within this world. And we look forward to working with everybody. And I hope everyone enjoys the rest of the breakfast. And I look forward to hearing about all the great work that everyone's doing. Thank you.
Thank you so much for that, Chris. To give us and paint a little bit of a picture of not only the challenges that are faced, but the effort, the continued effort that never stops to advocate, and the work that it takes on all facets that you discussed. And I know how hard you personally work at this, and I also appreciate that how difficult it is to get the ear and the attention of all the stakeholders that are necessary to make those changes happen. It's not easy, and certainly not easy when you're dealing also with governments and regulation and all the effort that you put into that. So thank you. And building on that, we've invited and put together what I think is an outstanding panel of members who can share their experience and their particular stories, as well as efforts, and moderated by Fiona DeMark, who is a resilience coach and an inspirational speaker and just a fantastic person. So I'm going to leave it to them to introduce themselves further and kick off this panel, and thank you very much.
Okay, I'm going to stand up for some of this because I don't like sitting down while I'm presenting. Thank you, everybody, for coming this morning. I'm going to introduce our panel, or we're going to introduce ourselves in a moment, and have a little bit of a conversation about how we're all living our best lives. So I was diagnosed with lots of things growing up. Actually, in fact, Adelaide is a bit of a stomping ground for me because I grew up in far western New South Wales in Broken Hill. And so Adelaide, which is 5 hours drive away, was my local capital city. And so my sister, who is older than me, was diagnosed incorrectly, and she was sort of, I guess, the test guinea pig in our family. And so after many years of her going to eye specialists, they realised that, okay, it's not Stargardt's. And then they said, oh, RP. And then they said, nah, not RP either. And so it turns out that I've got rod cone dystrophy. And so there's 3 of us. Elder sister has it, middle sister doesn't. Me, the little sister, has it as well. So I guess growing up in the outback, I had to learn to be really adaptable and resilient, and that's why I'm now a resilience coach to help other people learn about adaptability and resilience. And so I guess, when you've got an eye condition, you need to live your best life. Some people find it very difficult, and that's why services like Vision Australia are there to sort of support us and help us along the way. And the panel here has been very successful in what they've been doing, and I'm now going to hand over to get them to introduce themselves. So I'm going to start with Lily, if you'd like to introduce yourself, please.
My name is Lily. Some of you will know me as Adelina. In my time working at Vision Australia, Lily's my nickname and the name that I I use now as a para-athlete and motivational speaker. I have retinitis pigmentosa. I was diagnosed at 24, became legally blind at 35. I now have around 5 degrees of my central vision left. It's fairly functional, but as you can see, I have a thyroid problem with my mobility. This is clearly at my feet. I went on to become a school teacher, a mum of 2. I worked for Vision Australia for many years in various roles. And 3 years ago, I jumped on a tandem bike and I fell in love and started doing some crazy stuff, racing on a tandem. I got to national level, won a few medals. I competed in a World Cup here in Adelaide, 4th in the world where time trial was huge. I started this later in life, so I was competing against 21-year-olds, and we still managed to bring in all screaming around the Ben's motorsports track here in Adelaide at 40 kilometres an hour on a tandem was quick. So that's me. I now use all of my lived experience to inspire others to chase their dreams beyond their boundaries.
Beautiful. Thank you, Lily. And Emily, would you like to go next and tell us a little bit about yourself?
Oh, yes, the microphone's on. Good morning, everyone. My name is Emily Shepherd. For those who can't or who are unable to see me, I am a female. I have a blue stripy dress on and a navy jacket. First and foremost, I'm the parent of 2 fabulous children who are 17 and 14, and I'm also the CEO of Usher Kids Australia. So my son, who is 14, has retinitis pigmentosa caused by Usher syndrome, which also has the added bonus of a profound deafness as well. So just through a lack of having a home when he was diagnosed at age 3, I decided to set up an organisation that we now support over 60 or 70 families across Australia who have Usher syndrome, and we really bring parents together and young people together to share that lived experience, and again making sure that they can live their best lives. So that's me.
Beautiful. Thank you, Emily. And such great work that you're doing, bringing all of those families together and having those shared experiences. I think sometimes when we share experiences and we learn from each other, you get all those little tips and tricks and things that maybe you don't get told by the professionals. So that's really great support network. And Cameron, can you introduce yourself?
Press a button, do you? No, it's working. Good morning, everybody. It's lovely to be here too, and thank you for the introduction for this panel. I'm probably the oldest fellow here, been around for a long time and had vision loss for now 55 years. It's RP, which you're starting to hear about, retinitis pigmentosa, a genetic degenerative disease. It's been incurable, and only some hints in the future that it might be genetically modified are starting to emerge at great cost. Now, I started off as a farmer. My eyesight was okay. It was a bit of a later onset of RP when about the age of 28 or 29, it started to come on slowly. At that point, I gave up farming, came down to the city thinking I'm hopeless and useless and can't do anything, and had the good fortune to run into a service offered then by what was then the Victorian Institute for the Blind, now part of Vision Australia. And I went on to university, and they did all that study at university using tape recorders by a service which was organised where volunteers read books, sometimes 2 inches thick. It took about 24 tapes, which all had about 360 minutes of reading on each one of them, so you can work it out. It was a hell of a commitment by volunteers, and part of the commitment of a broader community towards supporting generally people with disability. However, getting through that, it became perhaps by good fortune, a chief executive officer of an industry organisation. Was in that for 14 years, got worn out on that and became a lawyer, back to what I studied at law at university, was a lawyer. Did a number of important cases there, and then finally ended up on a ministerial advisory panel called Planning Panels Victoria. Don't blame me for for Melbourne's lack of planning. I'm not in it anymore. And then the last 14 years of my life, I was working with Vision Australia, running what's called peer support groups, but the trade name for them there was quality living groups, and that was profoundly interesting and profoundly helpful, and we'll get back to that later in this talk. But as a result of that, I've produced a book which has brought a lot of the aspects of losing sight together, both practical and in many ways it is a combination of what I got out of the 14 years of that work. I think that's enough. Oh, I've got a guide dog too now. She normally speaks, but today, she didn't come over. She's got cold feet, and because she's got 4 and I've only got 2, I got the short straw.
Beautiful, thank you, Cameron. Okay, so we're going to learn a little bit more about what each of us are doing now. And I'm going to hand over to Lily to start off with. Now, Lily talks a lot about hope and how that has an impact on how we live our daily lives with vision loss. So I'm going to get you to talk a little bit more about that, please, Lily.
Thank you. Sorry, I hope you could hear me before. I didn't realise the mic wasn't on. I've got a big voice, so I didn't realise I hope you could hear me. But okay, let's talk about hope. Hope is at the centre of my world. I know Professor John Grigg is in this room somewhere. I hope he is, because 3 years ago, or almost 3 years ago, I had some gene therapy. And I think we were just coming out of COVID, and I had a Zoom meeting with Professor Grigg, and he told me about the gene therapy. They'd isolated the spelling error in my DNA. I had a 70% chance of that being found, and they did. So I was very excited that they found the error. And so Professor Grigg and I started talking about treatment. He blew my mind with all the science. But at the end of that conversation, he said to me, "Adelina, finally there's hope." And sorry, a week later, I can't lift my jacket sleeve, but I got the word hope tattooed on my left arm. It's in beautiful cursive ink. And every time I had a bad day, I look down at that tattoo now. So hope it drives everything that I do. It's not just a word for me. I also was around about the time that was happening that I jumped on a tandem. And I thought I was going to do it recreationally. And then I got this extraordinary pilot jump on the front. So the pilot is the person on the front, and the vision impaired athlete is the person on the back. They call us the stoker. We're the power. And she was a professional triathlete. She said, "You're pretty good at this. Lily, you're really good at this." I said, "Am I?" She said, "Yeah. You want to do a triathlon?" I said, "Nah, Lily doesn't run." But I'd like to cycle. So within 3 months, we were on a crit track, a criterium track at Randwick, flying around there. And she said, "You're not just good at this, you're really good at it. Let's go, let's compete." So we took off, and we started, in fact, at the end of that, speaking of hope, at the end of that event, we were approached by a Paralympic athlete who was a paracyclist who was on a trike. He had a physical disability, and he screamed out to us and he said, "See you at Nationals, girls." And I went, "Yeah, right. That's probably not going to happen." Well, Nationals was about 8 months ago, and I looked down at that tattoo on my arm and went, "No, you know what? Yeah, no, we're going for it." And we did. And first we had to do state, and we won a gold medal there, and then we went on to Nationals and we won bronze. I'd only been on that bike for, a year, less than a year. And but hope drove everything. It is. I also have another bit of ink on my right arm that says "Dream, Believe, Achieve." And I had a dream to become a paracyclist, and that was the dream. That was the goal. Again, hope that I could reach that goal. I had the second word says belief, and I had a belief. So coming back to hope, I use hope to drive visualization. I do a lot of visualization. I visualize myself on the podium. I visualize myself screaming over the finish line. I visualize the post-race hug I'm going to give my pilot. Visualization is huge, and it stems from hope. So and it works. Can I just say, it works. So if you keep I do a lot of work around mindset. I do a lot of work around, keeping hope in your heart, knowing with the work and the support, surrounding yourself with all of that work and the support and the training. I had to bring so much support into my life, and I know we may get a chance to talk about support, but I knew that the third word on my arm is achieve. So it's dream, believe, achieve, and the achievement is the work. So I knew I had a lot of work to do. I knew couldn't do this on my own. So not only do I need a pilot, and in triathlon I need a guide, and I need someone tethered to me in the swim. And I did do a triathlon. I've done a few now, but Lily still can't run, by the way. But it's driven by hope, all of it. So I had to bring a lot of support into my life. So I needed pilots, I needed guides, I needed transport, I needed a coach, I needed people to teach me how to train, how to eat, all those sorts of things you need to do as an athlete. But without hope, and I am, despite the bad press around the NDIS, I wouldn't be where I am today without it, because it helped fund the support that I need to be a para-triathlete and a para-athlete, a paracyclist. I couldn't do it without it. So I guess getting back to hope for where my vision could potentially end up, from the date of diagnosis, I never ever entertained blindness, not for a second. I still don't. I still live in hope that there'll be treatment. But what I did do is know that I have no control over the treatment and the cure, or whatever it may be. I'm going to leave that in the hands of the people in this room, those clever scientists and ophthalmologists and all those incredible people. You all now sit in what I call my God box. I have no control over the universe will take care of that for me. And do you know what? It's happening. When I got on a call with Eric, and he started telling me about the treatment, I still now just get shivers at the thought of that the treatment is there. It'll just be a matter of time. I speak to Professor Grigg and he tells me all the science and all the thing around all that stuff I don't understand around gene therapy and all that sort of thing. But I know it's not my job to understand that. It's my job to live in belief and hope that one day it will happen, and it is happening. And I'll end just with that hope is my guiding light. It's my guiding light. It keeps me going. And I know that everything I've done in my life up to this point has prepared me for the journey ahead, which is to inspire other people to chase their dreams beyond their boundaries, as I said. And if I can even just inspire one person, they don't have to get on a tandem and do silly things that I do, but just chase a dream, whatever that dream is. Thank you.
Beautiful. Thank you, Lily. And we all live with hope. It's part of everybody's life. We hope the train's going to come on time. We hope that, our friends are going to answer the phone when we call them. All of those little things in life. But then when you've got low vision, hope becomes something different. And so talking about inherited retinal diseases, when I had my children, it was very much cross the fingers and hope, because we didn't do genetic testing. In fact, my children were born through a donor program, so it was a bit of a mystery box, really. And so it was really just cross the fingers and hope. And I think when you're vision impaired or low vision, every day is full of hope. We hope that there's no construction on the footpath to obstruct our way. Chris is going to the restaurant and suddenly they're doing plumbing in the street. And what do? You don't fall down the hole. You either hope that somebody is going to come and help you, or you hope that you have the resources to find your way around those kind of situations. So we're all full of hope. And, Lily is a perfect example of how hope can then bring you to the things that you dream of. So next we're going to hear from Emily. And we're all really interested in clinical research in this room. That's our bread and butter, I guess. However, Emily is more interested in psychosocial research and how that impacts upon people with low vision and how we live our best lives. So I'm going to hand over to Emily now, and she's going to tell you a little bit about what she's doing.
Thanks, Fiona. When my son was diagnosed with Usher syndrome at age 3, we actually called we were in quite a distressed state as a family, thinking, what does this mean for our child? What does the future hold for him? We called a vision service and they said, oh, what is his vision like? And I said, he's 3. He might have a little bit of night blindness, but it's otherwise okay. And they said, that's okay. Well, why don't you give us a call back when it deteriorates? And I got off the phone thinking, what do I do? I don't know how to live. I don't know I don't know what to teach him. I don't know who to talk to. I don't know where to find that support. And that was a really, really frightening and isolating time for my family. And we learnt a lot about the clinical research that was going on and providing this hope that one day this may not be the trajectory for my son. And that did give me hope. But I wanted to live well now. I wanted to teach him skills that were going to give him the foundations for coping with this deteriorating vision. And I didn't really know where to go to find that. And with our group at Usher Kids Australia, we've been working with the most amazing clinical researchers who understand that you can't have clinical research without the psychosocial research. So the psychosocial research is looking at how are we living, what supports are in place, what is the impact of these conditions on our lives, what is the impact on us as carers or parents, what is the impact on siblings who don't have the conditions, what is the impact on our education, what if there are barriers. All of these things are able to inform the bigger burden of disease on our community, which then hopefully is able to translate into further research dollars into that clinical research. We talk about natural history studies, and natural history studies, of course, are tracking the disease progression. But in a natural history study, we're looking at someone's eyes only. And those eyes belong to a human. Those eyes belong to a child or a person or a loved one. And I would love to see more natural history of the progression of the experiences we have living with these conditions. How are we talking to our kids? How are we teaching our kids to live with the knowledge that they're losing their vision? How are we living with relationships or coming to terms with the grief and the loss that comes with these conditions? So that the natural history for me is a lot more about the whole person rather than just the eyes. And I would like to see more acknowledgement of the quality of life that we can live with if we're tracking that as well.
Thank you, Emily. And that's the most important thing, is to remember, those eyes do belong to humans. It's really interesting. I love that line because it's very true. We do need to take that holistic approach because we are humans. And even though you're looking at one tiny little piece of the puzzle, if you don't put that puzzle together, then that leaves somebody that is struggling and, maybe not getting the supports that they need. And that's where we lead into Cam, and he's going to talk a little bit about, I guess, when we've got vision loss, sometimes people are in that denial and avoidance kind of stage and they don't really know how to cope. I know for me, I was told very young, you're going to go blind. And it's like, oh, awesome, great. But it was something that I always grew up and knew. But if you don't grow up and know that, sometimes that is very hard to adjust to. So I'm going to pass over to Cam and he's going to talk a little bit more about that.
Thanks. I think we've got it. Yeah, thank you, Fiona. And yes, I will. And I'll start with something which I think's quite relevant, and because there's professors and medical people here. It sadly has been experienced, and Fiona's just confirmed it, and Emily has too a little bit, that when you as practitioners have encountered people who's have got an incurable eye disease and where your skills and expertise can no longer provide either direct assistance, surgery or cure in some way, so often, as Fiona's just said, they're just left, your clients are just left to go out into the wilderness. It happened to me, and even before I retired in 2019, a young lady from Queensland came down in tears because two practitioners said, look, you're going to stop, you have to get your driving licence. Another one just said, look, you won't be able to drive. End of advice. It is not good enough. And if I can appeal to you to go back to your profession, so please, if your professionals are encountering this, forward them on to the important service organisations, Vision Australia being national, and the guide dog organisations, and there's others like Emily's organisation, who, because my message is, through peer support, you can find one of the most valuable forms of assistance. As Fiona just said, you're left often where nothing can be done. You withdraw to yourself, sense of, well, there's no future, I'll survive, but I'll just go and do it my own way. And that concept, denial and avoidance, is very real. And in that state, of course, you're not going to have the hope that Lily's talked about. You're not going to have the hope that there's another life possible, nor the hope, for example, that I was given when I was told that I would go to university and I'd have tapes with books on them that I could read and study. It's very important to capture people in the early days of an incurable disease and direct them to what you'd call rehabilitation. And, for example, the hope that can be given through all the rehabilitation now is just amazing. Computers that talk and systems which are free. If they're not subsidised by government, they are actually literally free. Our phones talk. There's apps on your phone that talk, and so on. We could, and probably should list a few, but it's a bit boring to get into technology. But the sooner people with incurable disease, and particularly eye disease, can be told that they can do things differently, that's the best thing they can do, or you can do, certainly as professionals, to let them know that, yes, their life is going to change. It's tough, and if you don't get that early support, it's a very cruel and harsh life to lead where you think there's no hope, and therefore you're making all the mistakes that you needn't do, crashing into glass doors, falling down steps, etc. I've done it, and eventually when you realise that you can use a cane, or it's not the stigma in using a cane, you find out it's the best thing you could have done. And yet for years I was in denial about using a cane because I thought I didn't need it. It's coupled with, as Emily said, the capacity of people to understand what's happening in the psychosocial aspects of blindness, that if we capture, I use another phrase really, we didn't go to school to learn how to be blind. And once it happens, we really have to go back to grade 1 primary school to learn the basics again. But you will be different. But being different is no shame. It's actually a great, great thing to be outside the normal scope of ordinary life. Look at, in our case here, we've got people who are achieving because they know they can do things a different way. But to have the skills, it means that you can use technology. A lot of older people losing their sight with macular degeneration in later life say, oh, I'm too old to learn, I can't use technology, and it's scary. But that's wrong. In Vision Australia, we were training people in their 90s to use the iPhone, to use emails, and so on. We could all do it, but that understanding that to be different is not a shame, or it's not, in fact, it's probably a strength, because there's been blind doctors, one just the other day, announcement of a chap in the USA has become a blind engineer. I suppose he wouldn't want to travel over his bridges, to be rather cruel, but that's what we can do. blind sports people, blind writers, many of the famous writers of this world, and some artists were blind. So there's a hope, but people have to be directed towards knowing that they can do this another way. Now, I'll stop there because we want to go back to it.
Beautiful, thank you, Cam. And, you know, peer supports is one of those things that is really important. I know for myself, growing up in an isolated town, you know, it wasn't until I was probably about 15 that I met another person that was blind, that was in my own age bracket. Before that, old people were blind, not me. And all of a sudden I met these other people that were using technology and had resources, and suddenly I realised that there was a big world out there that I could conquer, and that was the turning point for my life. I know that peer support was so important. And the other thing that Cam mentioned was, you know, that avoidance of using the white cane. And, you know, I was probably the same. I used to wander around and, you know, do the things. And I'm sure people looked at me and went, what is, you know, like, I mean, when you've got the cane or you've got a guide dog, people understand what's going on. And it's not so much of a you know, social stigma, I guess. But if you're wandering around walking into walls and things like that, I guess people look at you and kind of judge you. And so you don't realise that you're doing it. You think, oh, I'm like everybody else, I'm going to be normal. But in fact, like Cam said, embracing where you're at is really important. And I think that's the biggest key to pass on to your clinical patients, is that, you know, there is resources and options and things out there for people to use. And, you know, there's those networks and those peer supports that will, you know, give people, you know, those things, that everyday practical stuff that we need when we've got low vision, that maybe you know, you don't necessarily know from an outside perspective. So sometimes that inside perspective is really important to have. And I'm just going to check how we're going for time. Yeah. Sorry?
We're going to switch and wrap up.
Yep. Wrap up, yep. So, yeah, so, I mean, we've heard from each of us, you know, the stories cross over. So, you know, we've got hope, we've got, you know, psychosocial research where we look at the whole person. We've got the peer supports and making sure that you don't, you know, avoid the situation and that you learn to embrace it. And I think all of those things go into messages that you can pass on when you're giving diagnosis, when you're giving ongoing, I guess, you know, clinical support to people. You know, those conversations that you have are really, really important. And, you know, it might be just one little message that you pass on to somebody that can change their life. So, you know, I guess think about the way that you're dealing with people, and remember, it is a human. It's not just an eyeball. Thank you.
For that fantastic panel. So we'll go ahead and I'm going to invite Lauren up while we switch here. I'd like to thank our panel, our first panel again, for just inspiring stories and lessons for all of us. Fantastic to hear. I don't want to say we're switching gears by moving to science. I look at it as more as we're all together. We're more mixing paint than anything else. And the next individual that I want to bring up and ask to speak to give us an overview of really what's out there in terms of therapies. I don't know. It's probably easier, Lauren, to probably describe all the things that you don't do, to be honest. So, which is probably sleep or stop thinking about vision science. So I think it's probably easier to do that. But it's truly my pleasure to invite up Associate Professor Lauren Aden, who's a leading voice here, not just in Australia, but globally, and to give us a snapshot of the IRD therapies that are out there. So welcome, Lauren. Thank you so much.
Great. Thank you so much, Eric. That's very kind. And yes, you're right, I don't sleep very much. Look, it's my absolute pleasure to speak to you all and give a little bit of a, I guess, 101 on some of the science that's happening around inherited retinal diseases. And we're incredibly lucky. We've got an amazing panel that's going to follow me up in a minute who are the world experts in this space. So we're incredibly privileged to hear from them as well. But what I really wanted to do is talk a little bit about the current ecosystem and some of the research that's coming through. And so I thought I'd take you right back to some basic science about the eye. So the eye is an incredibly complex tissue, as we know, and in a way, it kind of can be thought of a little bit like a camera to some degree. So the light comes into our eye and it's focused at the back at the retina, which is like the film in the camera. The messages are then turned from light into electrical signals, which are sent via your optic nerve back to your brain. And what happens in inherited retinal diseases is that the light-sensitive cells stop working, and so that's why you get this progressive or stationary vision loss, depending on your subtype of IRD. And so one of the huge challenges for us as scientists in this space is that there's lots of different causes of inherited retinal diseases, and those of you in the room who have had this journey will understand this. And we've talked before, I've heard about, how there can be misdiagnosis, and it's because it's a really complex group of conditions. There's over 300 different genes. They can be inherited in different ways. Sometimes they start when you're a child, sometimes they start when you're an adult. They can affect your peripheral vision first or your central vision first. And so you can see how it becomes really quite complex. The really exciting thing, and really what is starting to bring hope to this space, is that we have a whole range of emerging therapies coming up for different stages of vision loss. And so for those of you in the room who have experienced this, you'll realise that it's not a linear path. We often talk about, the slow progression of inherited retinal diseases. It can be quite variable. But what we find is that there are certain technologies that are going to be targeted more towards the early stages of vision loss, all the way through to when you've lost a lot of those light-sensitive cells and you need something to actually restore your vision. And so a huge change in our field has been the advent of gene therapy. And so I heard a little bit from Lily about gene therapy. It's very exciting. The first ever direct-to-patient gene therapy for any disease was for an inherited retinal disease, and that's Luxturna, which is now being given to patients in Australia, and it was approved here in 2020. With gene therapy, it really relies on there still being some cells that are viable in the retina. So it is more a treatment sort of for the earlier stages of inherited retinal disease. As the disease progresses and you lose more and more of those light-sensitive cells, we're then looking at the need to either replace the cells that have died or potentially change the function of other cells. So this is when we start looking into things like stem cells, which can actually replace cells that have been lost in the retina, and there are clinical trials underway. One was just announced in the last couple of days that will start shortly in the US, and that's about trying to replace the cells that have been lost. The other way of treating people that have more advanced vision loss is incredibly clever, and this is actually one of the techniques that Kiora is looking at, and it's actually changing the function of the cells that remain. So what happens in inherited retinal diseases is that the light-sensitive cells are lost, but the connecting cells, the retinal ganglion cells that take the light from the photoreceptors back through the optic nerve to your brain, they're still there. And so the idea behind this technology is, what if we make those cells light sensitive so they can then respond to the light that comes into the eye? And that's what the Abacus 1 trial has shown is effective. And I want to say a huge congratulations to Kiora, just in the recent news that there will be a phase 2 trial across Australia, which we're very excited about. In terms of other potential treatments, many of you may have heard of the bionic eye, and that's another potential technology that's being developed, and it's again for people that have quite advanced vision loss. The really exciting thing, I think, just from that quick overview, and I'm sure the panel will go more into detail into some of these technologies, is that it's addressing the whole spectrum of vision loss. One of the things we hear a lot from people is, what will be eligible for me and what's suitable, particularly because there's over 300 different genetic subtypes of inherited retinal disease. It can be quite stressful for people to know when will a treatment become available. And so it is quite reassuring that there's lots of different technologies being developed over time. In terms of what's happening in the space globally, there are obviously particular types of inherited retinal disease that are of really high research interest. Retinitis pigmentosa being one of those, choroideremia, in particular the X-linked forms of retinitis pigmentosa, where females often are carriers of the condition and their sons are affected, and also Stargardt and Usher syndrome. And the reason that these inherited retinal diseases have so much research at the moment is because there are clinical trials that are coming through for treatments. And so again, it's really important for people that have inherited retinal diseases to be aware of this kind of wave of emerging therapeutics and connect in with people. We're incredibly lucky in Australia. We're a very close-knit professional community, and across different states in Australia we have patient registries for those that have inherited retinal diseases. And if you're in the room and you're not aware of the one that's in your state, please do come and talk to us. In particular, I want to call out the Save Sight registry in Sydney. There's work going on in Adelaide. Fred Chen in Perth also has the Ward study, and we have a national registry called the Australian Inherited Retinal Disease Registry and Biobank. All of these registries are about basically collecting information on people that might want to be involved in clinical trials. And so in Victoria, we have the Venture study, which is again doing the same thing. And what we're really trying to do is what Emily was mentioning before, looking at these things holistically. So we want to know what happens to the eye. We want to get better at genetic testing, and that's something that Robin is an absolute guru at, and we'll talk about later. But we also want to know how to support people more effectively. These treatments are coming out, but they're not going to be a solves everything solution. So it's really important that we also have support in place as well. And on that, one of the things that our team are incredibly interested in is how people with inherited retinal diseases feel about some of these emerging treatments. And I wanted to give you some stats that I found really interesting. So we've just recently done a survey of about 1,500 people across the world. So there were about 700 in Australia and similar numbers globally. And if any of you in the room completed the survey, a huge thank you. This is a big thing. The survey took over an hour to do, and so it's a lot. The fact that we got that many numbers of people replying was amazing. What we did is we asked people that had inherited retinal diseases or their family members what they thought was important in terms of emerging treatments and how willing they were to take them up if they were available now. And it was very reassuring for us as scientists because we found that about 92% of people around the whole world were really keen on these emerging treatments. And in particular, we were asking about gene therapy. And so people said we would absolutely take them up if they were available now. However, only about 28% of people felt like they had good knowledge about these treatments. And this is a big challenge because the science is moving so quickly. And as you know, I kind of gave you a very quick 101 about the different types of treatments coming out. There's no way that anyone can, really in the community know every single thing about all of these different treatments. And so I guess my message to people is ask questions. Ask questions of your doctors, reach out to the researchers, go on the registries, sign up to Vision Australia and Retina Australia newsletters, try and learn what you can about what's coming up in the pipeline, but find someone you trust. Because one of the things in this space is that things change really quickly. And so it's really important that you're aware of the science behind the technologies as well as the promise and the hope that they might have. One of the other things that we've done as a national group of IRD researchers recently that I'm really proud of is a thing called the Priority Setting Partnership, and there's a number of people in the room that were involved in this. And what we've done is reach out and speak to people with inherited retinal diseases, family members, clinicians, researchers, about what we need to be focusing on in terms of the research. And if any of you are attending the conference, I have got a poster from our amazing lead researcher on this, Eden Robertson. And so it looks at what the priorities are going to be moving forward. One of the things that really struck me is that with all of these emerging treatments coming up, we can't do this alone. These genes are all incredibly rare. We think they affect about 1 in 3,000 people. So we think there's about maybe 19,000 people in Australia that have inherited retinal diseases. So to get the numbers that we need to really answer the big questions, we have to go globally. And so we're part of the Foundation Fighting Blindness, which is a big global consortium. As I mentioned before, we work all the time with our national and international collaborators. And we've got Andrea here in the room from New Zealand. This is how we move the field forward, is by working as a global group to really push this to the next level. In the interest of time, I'm going to wrap up now because we have got an amazing panel that I'd love you all to hear it from as much as we can. I did want to just touch back on education and knowing about what's coming up in the future, and just do a little bit of a shout out that we do have Professor Jean Bennett visiting Australia next month, and she is the person whose science led to Luxturna. And so if anyone is interested, she's going to be doing a public lecture in Melbourne, which will also be streamed online, and you can find the details of that on the CERA webpage, Centre for Eye Research Australia. But really, I think the take-home message is that there is such hope now. We really do have a lot of different treatment options coming up, and there are a lot of people working on this, across the community. And so hopefully the panel now will be able to explain a little further on that. And I'd like to thank again Kiora and Vision Australia for letting me give you a bit of an overview of where we sit in the world. Thank you.
Well, fantastic. Thank you again, Lauren. It's not an easy task to give a snapshot like that, but you are encyclopedic in that regard, so thank you. I will invite our next panel to come up, of Professor Bob Casson, as well as Professors Robin Jameson and John Grigg. Fred Chen, unfortunately, wasn't able to make it, so Lauren will kindly agreed to just stay up on the stage in case something else or a particular topic comes up. I'll let them introduce themselves, but I can tell you they are pretty much the black belts of IRD in Australia here. So I couldn't be more thrilled and thankful for them taking time. So Bob will moderate the session in the panel. I'll turn it over to him, but thank you again.
I'm Bob Casson. I'm not so much an IRD guru, actually, but I am an eye doctor and retinal scientist. I am involved in the ongoing clinical trial of Kiora's new drug. I just wanted to thank Kiora for putting on this event. We're at the Royal Australian New Zealand College of Ophthalmologists Annual Scientific Congress. This is the opening event, actually. So, in listening to all of this today, eye doctors are, just humans too, and we learn from our patients and draw inspiration from our patients. And I was kind of wishing that some of the trainee eye doctors had been here today, and maybe we can do this all again sometime. But so we've got a panel here of really super IRD experts. Do you want to just introduce yourself, just briefly, guys?
Hello, is that working? Yeah, hi. Hi, my name's Robin Jamieson, so I'm a professor of genomic medicine in Sydney, University of Sydney. I run a genetic eye clinic at the Children's Hospital at Westmead, and I also run a research lab in the Eye Genetics Research Unit, really aiming to develop some of these novel therapies that Lauren was speaking about, and also using technology like retinal organoids, where we take blood from patients and turn them into little mini eyes in the dish, and then testing our novel genetic therapies on those. And we also use those to test genetic variants that are difficult to determine. As Lauren mentioned, there's big advances in genetic testing, but as also previously mentioned, sometimes we don't find the answers. And so there's ways that we're working from a scientific perspective to try and really help in that space. And then also work with the ophthalmologists to be able to deliver those therapies, the gene therapies, and also understand exactly what's happening in the back of the eye so that we can give the right therapies to the right patients at the right time. It's a very exciting space, and very pleased to be here and speak with everyone about it, and also hear the incredible hope and experiences that people have talked about, which is amazing.
Hi, I'm John Grigg. I'm a professor of ophthalmology at Sydney University as well in the Department of Ophthalmology, and I run inherited eye disease clinics at both the Sydney Eye Hospital, the Saison Institute and the Children's Hospital at Westmead, so across all the ages, and also run the visual electrophysiology services there, which is important in helping the diagnosis of these conditions or unexplained visual loss. And that's led to us over the last sort of 30 years to really having a long association with a lot of people with these sort of areas of vision impairment. And in that time, we developed a partnership really with all the individuals, and that's led to the Save site to us starting a community and family day, which we started 12 years ago, to sort of try and address some of the issues where there's a gap between what happens in the clinic and what happens in real life. And that we're coming up in a couple of weeks' time for the next, and Lily's speaking of that, I think, as well, in a couple of weeks, kindly, thank you, where we sort of look at transition, starting school or starting high school or leaving that. And we've now got a young group of professionals who are helping people how they enter the workforce and deal with the situations there, which I think both Chris and others sort of talked about earlier. So there's some of those sort of, there's the other area is that because there's been the genetics, which Robin alluded to, has really now enabled us to sort of characterise the different conditions. It's meant that different therapies are coming in, so clinical trials are now a large part of what we do, whereas 5 or 6 years ago there was no clinical trials. Now there's a lot coming and a lot starting, so that's where we also need to come back and re-engage with people who've thought there was nothing could be done. Well, there is things that can be done now, and so we're now trying to develop the systems to have all these people come back into the care system to help engage with all these opportunities.
Yeah, and I'm Lauren, so I'm an associate professor at the University of Melbourne and Centre for Eye Research Australia. We have, I mentioned before, the Venture Registry, and so we are doing a lot of research, obviously, in inherited retinal diseases, and yeah, very much working with our colleagues across Australia to try and build up more information about both the natural history but also clinical trial outcomes. And in particular, I'm really interested in ways that we can better assess how these treatments impact people and their quality of life, and coming up with better measures for trials.
Thanks so much, Lauren. So I want to leave some time for a Q&A, but we might just first discuss a couple of things. So the Royal Australian New Zealand College of Ophthalmologists, RANSCO, has guidelines for the management of IRD written by these guys. Some of our colleagues may not be across them so much, but so we might just ask Robin, who with an IRD should get genetic testing these days?
So I guess I'm a geneticist, so I'm going to say everyone. But I think practically speaking, I really do think it should be considered for every family that's seen, every patient and family that's seen, because there really are huge opportunities that are coming through. So I think that whenever an ophthalmologist, and I agree with you, some of our younger trainees, it would be great if they were here actually. Every family that is seen, or every patient where this is coming up as a possible diagnosis, that genetic testing, they should certainly be referred for that or considered for that. But I must emphasise that it is actually important that they have the proper ophthalmic investigations, because I have seen some referrals where an ophthalmologist, the patient might have IRD, can we just have a genetic test? And I want to explain that when you do a genetic test, it's now a genomic test. And as Lauren mentioned, there's more than 300 different disease genes, and each of those is composed of, 20,000 base pairs. And so, it's a forest out there, and there's 3 billion base pairs that need to be analysed, or less than that if you just look at the IRD genes. So it can be very complex. And the problem is that we've all got different genetic variation. That's what makes us all look slightly different. And so sometimes it's hard to distinguish is that genetic variant, is it disease causing, or is it something that's just benign and not disease causing? And we don't want to give people the wrong genetic diagnosis. And so it's really important that people have their proper ophthalmic investigation to know what we're dealing with, because that really helps interpret the genetic testing. So that it can't be just a reflex, oh, you might have an IRD, you need just to go straight to genetics. I really think it's important that they have their proper ophthalmic investigations, and then they can be referred to a genetic service. And there's discussions about should the genetics be done by the genetics doctors, should it be done by the ophthalmology team, and different things are appropriate in different states. But I think whoever does the genetic testing and arranges that needs to be really across it and understanding what the patient's getting themselves in for, because there's implications. It's not only information for that patient, it's information for potentially family members. X-linked inheritance was mentioned, and so that can mean that a mother can be a carrier for a condition that she didn't realise. There can be a whole amount of implications for the rest of the family with other people in the family who might be at risk of the condition and so on. There's other issues in terms of that people might want to take advantage of. I mean, obviously, we're all hoping that there'll be a gene therapy or some other therapy that will be available for people, but there's other issues in terms of people might be interested in family planning, so genetic information for families, pre-implantation genetic diagnosis. So there's other things that are important for people to consider that are available in this day and age, and people need to be informed. I mean, it doesn't mean to say that they have to do them, and none of this, no one has to do genetic testing. There's a huge consent process that needs to happen, and it might be suitable for some people but not for others. And so it's a real discussion with the patient about that. And the other thing that I just want to mention, a whole new wave that's coming through in terms of genetic information is what's called preconception carrier screening. And there are actually quite a lot of private companies offering this now. And this is to young couples who are thinking about having children, and they're being offered testing of 300, 500 genes. They're otherwise normal individuals, they're not aware of a family history. And so what is happening out of that is that they're finding out actually that they're each carriers for a particular genetic condition. It could be autosomal recessive condition. And so then there's a lot of angst when that happens, because this is a real surprise to people. And so I do think this is an important issue in terms of the vision support agencies, the peer support agencies, because these people, and the ophthalmologists obviously, because they need to understand them. So they're potentially, if they're both carriers, they're potentially at 1 in 4 risk of a child with that condition. And so they don't know what that means. They need information about what that means and discussions about the possible opportunities or not for them, or what they might want to do about that. So I think that's a new wave that's going to come through to the ophthalmologists, to the vision support agencies, to the patient support groups, for people to understand the implications and what that may mean. So it's a burgeoning space, and there's a lot of information. And it's a real partnership journey with patients. Like, there's no right answer for, there's no dictatorial thing. You have to have genetic testing or anything like that. It's a real discussion with people about what works for them, what works for their family.
Thanks, Roman. Earlier, actually, Cameron brought up a really interesting point about the long-term follow-up of patients with IRD. So it's, it may be appropriate, of course, for the treating eye doctor to refer patients to Vision Australia or, See Differently, other services and so on. But John, should the treating eye doctor continue to see patients with IRD like forever?
Look, I think that's a good question, Bob. And I think in the past what's happened is some people would say yes and some would say no. And then the people sort of returning to the regular doctor sort of think, well, they're not saying anything, they're just saying, and there's no treatment. But I think it really has changed now. And there's two sort of important things. There's sort of opportunities for different types of treatments coming, which could be non-genomic, and then there's potential genomic ones. But importantly, there is an opportunity to really touch base and work out what supports are available. And so there's a lot of, with the NDIS now, there's a lot of opportunity to gain further support, and they've all got detailed forms to be completed, and that's an opportunity to have those completed at. I think I can see Andrea Vincent here as well. We're all inundated with forms to complete now, and to do those, you really need to have a recent update with your ophthalmologist. And I think that's another sort of black hole where what's the right answer for the agencies to get the right support for the individual? And that's sort of something we struggle all the time to try and help people get the support that's necessary to participate in the community. So there's sort of a number of things. There's sort of all those sort of social supports are really important, and that's why I think it's still important to come along. Mm-hmm. There's updates that keep happening, and I find, seeing people every 1 or 2 years, there's often so much has changed now that there is a real opportunities now. There's sort of different sort of therapies or different updates on what therapies are, and then in the background, it's helping us provide an understanding of the natural history, which is then going to be important for studying the outcomes for therapies and developing endpoints for the therapies, which are quite challenging at present. I think Lauren mentioned before, one of the things is that the IRDs in general are slowly progressive. So how do you monitor change? And when you're introducing new therapy, is it just a natural history that it's stable for that period of time, or did the therapy actually do that? And that's where the real trick is. So trying to identify new biomarkers is what a lot of us are trying to work on. And it's how to, and that's where those visits as well. So there's a couple of key points, I think. In the background, there's biomarkers, which as a person affected, you get sick of having all these tests and bright lights, but they are important. But there's also the psychosocial things, which are getting the right forms and the right supports. And those are touch points that can occur in those consultations.
Thanks, John. Yeah, so it's still kind of a two-way ongoing learning.
Yeah.
Lauren, I just wanted to know, where's the bionic eye at now?
Yeah, it's a great question. So that actually was how I actually got involved in IRD research, actually, was through the bionic eye. So there were 2 programs running, one in Melbourne and one in Sydney. And the patients that had the implant were all in Melbourne. So there's been 7 people that have received the implant there. The implant in Australia that was used in the clinical trials is what's called a suprachoroidal implant. So what that means is it goes in behind the blood vessels at the back of the eye rather than being tacked onto the front of the retina. And so it's a safer surgery than some of the other devices around the world. What we did find is that the devices helped people with sort of navigation and obstacle avoidance and finding objects as well. The company that spun out from the research is actually in the process of finding funding, and they're then hoping to go into an international study. So yeah, that's sort of where it's sitting at the moment.
Thanks, Lauren. We might move to a Q&A, just take questions from the floor. Has anybody got a question? Yeah. Okay, we got Cameron and Chris.
I'll hand the mic to you, Cameron, here.
Thanks. Thanks very much. The question is about the bionic eye. There's a hell of a lot that's interesting, but I thought there was another bionic eye being developed by Monash University where the chip was being placed in the brain rather than behind the eye. Is that program developed or died?
Yeah, that's a great question, and you're 100% right. So that was the Monash Vision Group. And again, I spoke before about how we all work quite closely together. We were really lucky. We were involved in their clinical trial planning as well. And so, yeah, I do know quite a lot about that project. Unfortunately, they hit the age-old problem of funding. So they had funding and then it dried up, and so they haven't been able to go into clinical studies, which is a bit of a shame.
I've got 2 very brief questions. One is, when I did my genetic testing, it was inconclusive. One, I was just interested in how common is that? And then the second question is, it's sort of related. The buzzword at the moment is AI. How's that going to impact, the ability to be able to analyse some of the results from this testing?
Yeah. So, Yeah, that's a great question, and that remains one of the issues with genomic testing for IRDs, as I mentioned. Approximately, depending what series you look at, about 30 to 50% of patients do have an IRD. We don't get a genetic answer. In the genetics world, that's actually considered a high success rate. We're in a situation where we're in one of the better situations from the genetic testing world, but of course we want 100%. I mean, that's what we're gunning for. So there are a number of ways of looking at that. One of them is that as time goes by, the technology is improving. So one of the initial things that we're giving advice to people, we actually take them through a process of, if we get a situation where we haven't found a variant in a person, so say we do the genetic testing is done, we get a clear-cut answer, that's good. We can put the person on the trajectory of, there's either a therapy available, there's a clinical trial available, or it's really important that you come back for your 1 to 2 yearly review so we can monitor your natural history, so that when a therapy becomes available, you're in the right place to be part of the clinical trial. If you're a person where we haven't found the genetic answer, or it's not clear-cut, like it's a variant of uncertain significance, we're not sure what's going on, we actually run a national ocular genomics multidisciplinary team meeting where geneticists and ophthalmologists around Australia can refer to that meeting, and what we do is we have our expert team there of the laboratory scientists who are experts in looking at the genomic data and the reports. We have the IRD specialist team there who looks at the images get sent in virtually of the phenotype of the patient, the clinical ophthalmic phenotype, and we have the clinical genetics team there. We have our research team there to all work on, can we get this across the line? Because sometimes with increased knowledge about genomic and genetic testing, there's been specific criteria developed. Because as I mentioned, there's 3 billion variants across the genome, and mistakes have been made. So people have been told, you've got this particular disease gene, and it's not that disease gene, because they jump to conclusions. And the problem with that is, if there's a genetic therapy and they're given the wrong genetic therapy, well then that's a no-win situation, because then they're not then suitable for their proper genetic therapy, because there's problems with the delivery vectors and so on, and so they might have immunity, and so then they can't get. So that's a crime. So we do not want to give people the wrong genetic diagnosis. So that's why we spend so much time trying to get the right genetic diagnosis. And so we have our whole team look at those genetic variants, and sometimes by really looking in detail at the clinical phenotyping, we can actually get it across the line to a definite pathogenic or likely pathogenic variant, and we can solve the case, and we've then got the answer for the patient. For a patient where there's no variant that's looking like it could be the answer, then we are taking research routes, looking at other approaches. There's new genetic technology coming along, long-read genomic sequencing, other avenues. And so, again, we are taking patients down that route. Or sometimes it's a variant of uncertain significance and we can't get it across the line by looking at the detailed clinical phenotyping or reanalysing the variant. And so we're actually, those patients and samples we're taking to the research lab, we're taking blood from the patient, or we're using stem cells from a normal person, genetically engineering in that particular variant and then developing them, those into little eyeballs in a dish, and then using biomarkers to try and determine, is that a clear-cut pathogenic variant or is it just a benign variant, to really try and help get a genetic diagnosis for those patients. So it can be a long road, but we really want to get to the genetic answer, for 100% of people if we possibly can, and then get the right genetic answer for people so that they're on the right therapy path.
I might just jump in on the AI question as well, which is an excellent one. And AI obviously is going to be very important in genomics as well. We've been really interested in terms of the image analysis as well. So obviously when someone comes in to see us, we take 1 million photos of the back of the eye. And when we look at the back of the eye, we can look at certain aspects of it, but AI has got the potential to even do a better job than humans at analysing those images. One of the challenges to date has been that the back of your eye is actually unique to you, and so it can be identifiable. So we have to be incredibly careful about sharing data. And when you do AI models, you need tens of thousands of images. So you have to share between sites. A big advance has happened recently called federated learning. I'm getting into some of the jargon now, but it's basically AI models where you can use certain software across different sites and do that without having to share the data. So I think it's going to happen in the very near future that we'll be able to use AI for image analysis at quite a large scale, which will answer a lot of questions.
Yeah, and thanks, Lauren. I didn't forget to mention that AI, of course, is useful in looking at all those variants across the genome and really upping that diagnostic rate with looking at the genetic variants and linking them up together and relating them to the functional aspects that we have. So yes, AI is certainly going to be helpful, but it still needs a human at the end to interpret it and make sure it's correct.
Hi, my name is Lauren and I have late-stage RP, and I was just wondering, probably about 12 years ago now, we decided to get try to find our gene mutation, and we sent our bloods to Estonia, and we went by the genetics department at Flinders, who are fantastic, and they test for the two most common RP genes, and they came back negative. And then they said, "Oh, do you want to pursue it?" And we said yes. So that was going to cost about $10,000, and I said, "I don't care, just go for it," because the reasons you've pointed out today why it's so important to try to find out your gene mutation. So the genetics department at Flinders said, "Look, just leave it with us," and beneficial to us, they actually found out a research clinic in Western Australia that has some research dollars, and they found out our gene mutation, and it didn't cost us anything, which was a bonus. But in what you're saying, is that an accurate diagnosis with the mutation that we've been given, or do you think it's worth pursuing that to make sure it actually is the right gene mutation that we've been diagnosed with?
So,
does that make sense what I'm saying?
Yes, it does make sense, and I think that's a reasonable question. I think that it's likely that it is the correct diagnosis, but I think if you want to be sure, I think it's important that you go to a local genetic service. So some testing has been done through research avenues, and that can be correct and often is, but I think in this day and age we need to be working on a clinical service basis. And a clinical service basis means that variants are looked at by what's called a NATA accredited lab, which is the diagnostic service in Australia, and that's the actual correct way. And so a way to do that is to have a referral to your local genetic service, and I know that there's people interested in IRD genetics in South Australia. I think South Australia is where you're mentioning, and so you can get a referral to them to have a discussion with them to be sure that the information that you've been given is correct. And also, if there's any family information or relevance that genetic variant might have to other members of your family and so on. Because sometimes in families, even if it's autosomal dominant disease, that's important because of the hereditary factors. If it's X-linked disease, that's important because of the hereditary factors in other family members. And even if it's autosomal recessive disease, sometimes there's a carrier screening that can be done in a partner depending on the frequency of those variants in the population. So there's a lot of information that derives from the genetic variants, not only in terms of potential therapy, but also important factors for the family in terms of considering the events that might be relevant in that way.
Thanks.
It's Emily speaking. I just wanted to touch a little bit on the delivery of information or the delivery of diagnostic information. We continually get families coming to us who are given pretty horrid delivery of information, being told, oh, well, this is the diagnosis, it's unlikely that your child will ever get a job, go home and just enjoy life, without any follow-up of support or referral to support organisations or really understanding the IRD landscape and that giving them hope. How do we do this better, and how do we as a support group work with local genetic clinics on making sure that they're giving families accurate and empathetic diagnosis?
Yeah, you want to
Well, I think it's more that the fault lies at the ophthalmology clinics, and we're getting that they're going to be blind and nothing can be done. And that's sort of an education process for the general ophthalmologists. I mean, those who deal with this sort of condition all the time know the processes and have, I suppose, with experience, have learnt how to deliver that news. I mean, the news is devastating. I mean, that stimulated us at the Safe Site to try and we funded then a patient care coordinator to make that link, because often what happens is you hear this diagnosis, you only hear where you could be blind, but that becomes blind, and so you walk out the door with a note to say to go to Vision Australia, but it takes 6 weeks to get an appointment, so what do you do in between? And so we've funded this position called a patient care coordinator to try and link that, and that becomes that liaison because all the doctors are busy, and so you can't get answers, and so that becomes a conduit for that sort of thing. And that's worked well. We'd just like another 10 or 20 of those. I mean, the UK has that they call it iClinic liaison offices. They've now just passed 100 across their things. We've got one here. I know the person who we've been going for now since 2015 with that, and that's all funded through philanthropy. And that's sort of, the first person came from Vision Australia to work with there and then went back, and the current, I know Vision Australia has been trying to set up a similar sort of model, which I think is excellent, but it's sort of how do you get the people connected with that person? And that's and so that's why we thought it was important to have them in the centres where the diagnosis is occurring or where the testing is occurring. And so the current person we've got, she's a social worker, she's really good, and she helps go through those myriad of forms, because there's a study that we've done, which followed on from the health economics one. We looked at 30 people consecutively who took part in their health economics study, they were just chosen from the clinic, and did they have all the entitlements they did? And 29 out of 30 did not. So there's a huge gap there of trying to get the right support services, and how do you do that? And that's sort of, we're trying to fathom how do we sort of help those people. And so that's where we're talking about advocacy. I mean, that's one area to government. I mean, we're trying to have those support people to make that linkage, and then they will sort of be able to try and help the next stages. Because I think when you get that diagnosis, it's devastating, and you go home and you just hear the worst things. But I think there is, you're not going to go blind straight away with this condition. It'll take decades or maybe never in your life. And so that's where we've got to try and change that perspective. I mean, just a slightly parallel sort of thing is that currently many of you will have been through the process of having so-called blind registration in Australia and having the forms filled out, which then send a link, which then enables you to get a sort of a carer's allowance or a separate blind pension. Now, in Australia, we cannot find out the number of people who are registered blind and what they've got, and yet the ophthalmologist has filled that form out. And so last year, following a Vision 2020 meeting in Canberra, I wrote to the Social Service Minister and haven't heard back. But that's somewhere where, for advocacy, I think Vision Australia or Retina Australia, if we combine together and write to them, because in the UK they do that, and they can tell you geographically where all the people are with severe vision impairment, and then help provide services in those areas. But that information is held at Centrelink, and yet we don't have that. And so that's one of our frustrations. If you're looking at a service delivery level, that would help with resource allocation if we knew where they were. I mean, obviously that's, and Glaucoma Australia would be interested in, Diabetes Australia and sort of Macular Disease Foundation all would like that same information. So
I just want to give a big round of applause to our panel members. So thank you very much for that. a lot of moving parts and a lot of complexity, with a number of different facets that cover science, empathy, the universe, so many elements. And I do think it's nice to have this venue in order to again, I take a step back. Our goal today, from Kiora's perspective and Vision Australia's perspective, was just create a little micro environment where we can take a little opportunity to get a Polaroid, to get a snapshot, share a little bit. I know I learn every day, and it keeps me active. I certainly learned today things that I didn't know 24 hours ago. And I have a number of people to thank. First and foremost, our guests, our panel members, those of you who traveled here to attend this little gathering. I just want to thank you from the bottom of my heart. It means a lot to us and to me. And I certainly want to thank all of our speakers and panel members, along with our colleagues at Vision Australia, in particular Liz Deuce, and my colleagues' leadership at Kiora, Praveen Tile, our chair, and Brian Strem, who's here, our CEO, and in particular our Australian team, and Kimberly Daniels for her efforts in organizing this. We will be wrapping it up here. We do have the space for a little bit, so please feel free to just, if you do have any remaining questions or just want to liaise. I know people have to get on with their day, and so if that's the case, again, thank you very much. But if not, we'll be here for the next 30 or 40 minutes or so. So again, thank you very much for attending, and hopefully look forward to a future event. So.